Good evening, folks. Welcome to Superpoints. And today we are going to discuss very important topic, femoroacetabular impingement syndrome. Whether you are taking USMLE, Step 1, Step 2, Step 3, Family Medicine Board, Internal Medicine Board, or NEET, this is a very, very important topic. We are going to discuss this topic in and out. So listen carefully because every sentence is very, very important. Let us start with this question. A 28-year-old female physical therapist assistant with a high active level running 20 to 25 miles per week yoga presented with an 8-month history of insidious onset, deep anterior right groin pain. The pain was sharp with activity and reproduced by prolonged sitting, theater sign, deep flexion, and squatting. She had failed conservative management with rest and NSAIDs. Physical examination revealed significantly decreased right hip internal rotation, 10 degrees compared to 30 degrees on the left, and strongly positive FADIR, flexion, adduction, internal rotation, and Faber tests, which reproduced her exact groin pain. Radiographs demonstrated a bony prominence at the femoral head neck junction, giving the appearance of a pistol grip deformity and an elevated alpha angle 68 degrees. What is the most likely diagnosis? All right, folks, we have four options here. Sorry, actually, five options here. Please choose the best answer and we will discuss. So the correct answer here is B. All right, let us see why this is B. Femoroacetabular impingement is a structural hip disorder characterized by abnormal morphology of the femoral head and acetabulum, leading to pathologic contact during hip motion. This repetitive mechanical conflict results in labral injury, cartilage damage, and ultimately early osteoarthritis, particularly in young active individuals. So, this is happening here, all right? This is the focus of pathology here, all right? There are two types, cam type FAI and pincer type FAI. So in cam type FAI, it specifically arises from an abnormal bony prominence. You see the bony prominence here? So this bony prominence is what is causing the problem, and it disrupts the normal spherical contour of the femoral head. Okay, so in the pincer type, there is acetabular over coverage of the femoral head, leading to impingement at the acetabular rim rather than a femoral head neck deformity. So based on, like, for example, in this question term we saw this thing, all right, there is like pistol grip deformity. So if you see that word, that itself is a big clue that this is cam type FAI. Okay, if you see pistol grip deformity or alpha angle more than 55 degrees. So let us see this cam type FAI. It specifically arises from an abnormal bony prominence at the femoral head neck junction, which disrupts the normal spherical contour of the femoral head. During hip flexion and internal rotation, this bony bump impacts against the acetabular rim, producing shear forces that damage the labrum and adjacent cartilage. Clinically, patients present with deep anterior groin pain, pain exacerbated by hip active flexion activities like running, squatting, prolonged sitting. So this is called theater sign, and there is reduced internal rotation of the hip, positive FADIR test. So when you do this, FADIR stands for flexion, adduction, internal rotation. So that is more specific. You may be able to elicit both FADIR test and FABER test, but more specific is FADIR test. That's a important question on its own. So FADIR is more specific to this particular syndrome. So radiographically, CAM type FAI is identified by pistol grip deformity and increased alpha angle, more than 55 degrees, indicating loss of femoral head sphericity. Early recognition is critical as untreated CAM type FAI is a well established cause of premature hip osteoarthritis. Now, how do you remember this? So, this is what I used for my exam. CAM curve adds mass. All right, CAM. So, curve adds mass. So, if you see in this diagram, this curve is adding the mass. That is how you can remember. You can even extend it. C for curve lost, femoral head is no longer spherical. A for alpha angle, more than 55 degrees. That's a key radiologic marker. Then there is M for bony bump at femoral head neck junction. All right. So high yield one liner is cam is femur bump, pincer is acetabular over coverage. All right, that one sentence give the entire pathology of this problem. In CAM, you have a femur bump. In pincer, you have a acetabular over coverage. So if this is acetabular, this is the femur, all right, femur head is covering like this. This is normal, okay? This is normal. But in pincer type, there is over coverage. So this acetabulum is covering a lot of surface. In fact, in the anterior region, it is covering more. That's why there is this backwardness. So the anterior side is covering more, and there is this backward slide in these patients. So pincer type FAI. Now let us go to the incorrect answers. It's very important you learn incorrect answers because the key distinctions help you to learn a lot of information. So do not neglect incorrect answers and knowing why those are incorrect answers. Okay. So why not this a pincer type? So, in pincer type, FAI results from acetabular over coverage of the femoral head, leading to impingement at the acetabular rim rather than a femoral head neck deformity. Key distinction pincer type FAI is caused by an abnormality of the acetabulum, whereas CAM type FAI is caused by a bony prominence at the femoral head neck junction, as seen in this patient. Next, C. Why not developmental dysplasia of the hip? DDH is characterized by a shallow acetabulum causing inadequate coverage of the femoral head, typically presenting with instability rather than impingement. So, in DDH, it involves under coverage of the femoral head due to a shallow socket, whereas FEA involves abnormal contact due to excessive bone or altered morphology. Why not avascular necrosis? In avascular necrosis, there is ischemic necrosis that is due to causing a lot of problems. And AVN is a vascular disorder causing bone death and collapse, whereas FAI is a mechanical disorder caused by abnormal joint morphology and repetitive impingement. So, avascular necrosis, the term itself says it is due to lack of blood supply. Then why not SCFE, slippered capital femoral epiphysis? SCFE is a condition seen in adolescents in which femoral head slips posteriorly relative to the neck due to a weakened growth plate. SCFE is a growth plate disorder occurring in adolescents. All right, it's a growth plate disorder, but there is a connection, and we are going to have a entirely one question on that connection between SCFE and CAM coming up after this. So, CAM type FAI is a chronic structural deformity seen in young adults. All right. So, if you go by location of pathology, for example, CAM, you are seeing a femur problem. In pincer, you are seeing a stabulum problem. In DDH, you are seeing an alignment problem. In avian, you are seeing a blood supply problem. In SCFE, you are seeing a growth plate problem. So you see how pathologically they are different from each other. Next, super formula. Young active patient, insidious deep groin pain, pain with flexion, squatting, theater sign positive, decreased hip internal rotation, positive FADIR test, radiography shows pistol grip deformity, alpha angle more than 55. So that is CAM type FAI. All right, if you see those keywords, all right, super formula is about how to recognize a particular answer by those keywords. The keywords, when you see these things like patient has groin pain and squatting pain, there is positive FADIR, there is pistol grip deformity on X-ray, alpha angle more than 55. If you see those, go for it. It's CAM type FAI. So, what is the super point here? CAM type femoroacetabular impingement is a clinical condition in young active patients characterized by activity related groin pain, decreased hip internal rotation, and a positive FADIR test caused by a bony prominence at the femoral head neck junction. All right, so this is the very important question. So, next we have another question. Please take a small break and we are going to discuss that question. So, in this next question, a 23-year-old male athlete presents with progressive right groin pain that worsens with hip flexion and internal rotation. Physical examination reveals decreased internal rotation of the hip and a positive FADIR test. MRI of the hip is performed to evaluate for femoroacetabular impingement. The radiologist measures the alpha angle by drawing a line from the center of the femoral head to the point where the head loses its spherical contour, and a second line along the axis of the femoral neck. Which of the following alpha angle values is considered the threshold for an abnormal result suggestive of CAM type femoroacetabular impingement? All right, folks, it's a very easy question if we had followed what I said earlier. So choose the correct answer and we will discuss. So the correct answer here is D, 55 degrees. All right. Let us say alpha angle measurement. That is the topic. What is he talking about? What is alpha angle in the first place? Alpha angle is a radiologic measurement used to assess the specificity of the femoral head and identify camti femoroacetabular impingement. It is most commonly measured on axial MRI by drawing one line along the axis of the femoral neck and another from the center of the femoral head to the point where the head loses its normal round contour. In CAM type FAI, a bony prominence at the femoral head neck junction disrupts the smooth articulation of the hip joint, leading to abnormal contact during movement. The alpha angle quantifies this deformity, and a value greater than 55 degrees is considered abnormal, indicating loss of femoral head sphericity, and an increased risk of labral damage and early osteoarthritis. So if you see this diagram here, folks, is very important. The normal angle, you see, this is alpha angle. The alpha angle here is normal. It is 42 to 50%. It can be less than 40. It can be less than 50. But if it is more than 55, that is the threshold. Okay. If it is more than 55, we are looking at CAM type FAI. And earlier I told you, pistol grip deformity. That is another clue to CAM type. So normal is less than 55, abnormal 55 suggests CAM deformity. What is the supermnemonic? The mnemonic I use here is alpha above 55, CAM is alive. Say that to yourself. Alpha above 55, CAM is alive. So if there is any suggestion that alpha is above 55, you can pick that answer. It is CAM FAI. So if the alpha angle crosses 55, the femoral head has lost its smooth curve. Think camp type FAI. So other things, 35 is well below normal, 45 is considered normal, 50% is borderline, 70% is clearly abnormal, but not the threshold value being asked. So if you see this in a question like there is an young patient, groin pain happening, positive FADIR test, pistol grip deformity, alpha angle more than 55, that is CAM type FAI, femoroacetabular impingement. Super point here is an alpha angle greater than 55 degrees on MRI indicates loss of femoral head sphericity and is diagnostic of CAM type femoroacetabular impingement. All right, folks, next question. CAM type femoroacetabular impingement is most commonly seen in which of the following populations? Yeah, if you have been listening, this is also another easy question you can answer very quickly. So the correct answer here is B. All right, this is a young people's problem. All right, that is the correct etiology here. The epidemiology, let us say, CAM type femoroacetabular impingement is a structural hip disorder characterized by a bony prominence of the femoral head neck junction, which disrupts normal joint mechanics and leads to abnormal contact between the femur and acetabulum during movement. This repetitive impingement results in labral injury, cartilage damage, and early osteoarthritis. So you are seeing early osteoarthritis, and the typical patient is young and active. All right, that's very important. This patient is an young and active patient. Because of this structural deformity, he is having lot of groin pain. All right, that is so. When you see this question, do not think, oh, hip pain. This must be an older guy, an older woman. Yes, osteoarthritis happens in older women most commonly. Don't fall in that trap. All right, this is an young people's disorder. Epidemiologically, CAM type FAI is most commonly seen in young athletic males, particularly those involved in activities that require repetitive hip flexion, rotation, and hip mechanical loading, such as soccer, hockey, and running. It is thought that increased mechanical stress during skeletal development may contribute to abnormal bone formation at the proximal femur, predisposing these individuals to CAM morphology. Recognizing this demographic pattern is essential as it helps guide early diagnosis and management in patients presenting with activity related groin pain and reduced hip range of motion. So, when you see young people, this is important to recognize it because if you do not treat it, they are going into early osteoarthritis. So, how do you remember this? This is the one I used FAI CAM competitive athletic males. All right, FAI CAM competitive athletic males. So, you can use this mnemonic to remember that it happens in athletic males. CAM type FAI is most commonly seen in young athletic males due to repetitive high load hip activity. Next, incorrect answers. And this is a beautiful way to learn, going through incorrect answers and their descriptions, because the key distinctions help you to understand which disease is more common in which demography. All right. For example, elderly female, they are most commonly affected by degenerative joint diseases like osteoarthritis or osteoporosis related fractures rather than camp type FAI, which is a condition of younger individuals. The key distinction is camp type FAI occurs in young athletic males, whereas elderly women are more prone to age related degenerative bone conditions. Let us say obese middle aged adults. What is more common in this group? Obese middle aged adults are more likely to develop primary osteoarthritis due to increased mechanical load rather than CAM type FAI, which is linked to abnormal bone development during adolescence and athletic activity. Key distinction here is obesity contributes to degenerative joint disease, whereas camp type FAI is due to developmental bony morphology in active young individuals. Why not children under 5? Camp type FAI does not typically present in very young children as the condition develops after skeletal maturation. So, because this happens after skeletal maturation, you don't see this in children. And what is the key distinction? Camp type FAI is a post adolescent condition. It's a post adolescent condition. Whereas children under 5 have immature skeletal structures without this deformity. You see, folks, even going through these incorrect answers, we are learning a lot. And then E, post-menopausal women. Post-menopausal women are more commonly affected by osteoporosis and fragility fractures rather than CAM type FAI, which is associated with young, physically active males. Key distinction is post-menopausal women develop bone loss related conditions, whereas CAM type FAI is linked to increased bone formation from athletic stress in youth. All right, folks. Super formula, when you see a young patient, all right, young and highly athletic activity, abnormal bone remodeling at femoral head neck junction, pistal grip, alpha more than 55, that is CAM type FAI. So CAM type, the super point here is CAM type femoroacetabular impingement most commonly occurs in young athletic males due to repetitive hip stress during skeletal development leading to a femoral head neck bump. Next, which of the following conditions is most strongly associated with the development of CAM type FAI? I already gave you a hint, so this question also should be easy to answer. You see how many different ways these questions come. Okay, you are seeing from pathology, from epidemiology, radiology, and this question is about what are the risk factors, and now we are going to see questions on how to treat it. So you can get questions from different aspects of this condition. So let us see this question. The correct answer here is C. All right, C, SCFE is like, let us see, basically this is etiology. Etiology of camp type femoroacetabular impingement, role of slipped capital femoral epiphysis. So what are we saying here? Camp type femoroacetabular impingement is a structural hip disorder characterized by a loss of normal sphericity of the femoral head due to bony prominence at the femoral head neck junction. This abnormal morphology leads to repetitive impingement against the acetabular rim during hip motion, resulting in a labral injury, cartilage damage, and early osteoarthritis, particularly in young active individuals. One of the most important predisposing conditions for CAM type FAI is slipped capital femoral epiphysis. So basically, when you see the femur, what is happening? So this is like a growth plate disorder, right? So because this is a growth plate disorder, there is that movement which is actually creating an inflammatory stimulus for the development of that bony bump. So that is why SCFE is a risk factor for CAM. Even after healing, SCFE can leave behind a residual deformity at the head neck junction, disrupting the smooth contour of the femoral head and leading to CAM morphology. Recognizing this association is critical as it links a pediatric hip disorder to the later development of mechanical impingement and early degenerative joint disease in adults. So, what is the super mnemonic here? The mnemonic I use is this one, SCFE CAM. So make it like safe cam. Safe cam. So safe is for SCFE, slippery capital femoral epiphyse. And then CAM is for CAM type FAI. So safe CAM is a very easy mnemonic to remember. Why not osteoporosis? Again, these incorrect answers and key distinctions are a beautiful way to learn more and more medical science. So why not osteoporosis? You see, osteoporosis is characterized by decreased bone mineral density and increased fracture risk, particularly in older adults, and does not cause structural deformities of the femoral head neck junction. So, what is the problem? Femoral head neck junction function. You need to think about which condition causes affects this particular area, femoral head neck area. Definitely, a CFE is there. You can't think of osteoporosis. So osteoporosis is a bone density disorder leading to fragility fractures, whereas CAM type FAI results from a structural deformity of the proximal femur. Why not rheumatoid arthritis? Rheumatoid arthritis is a chronic autoimmune inflammatory disease affecting synovial joints, leading to joint erosion and deformity, but it does not produce the bony prominence at the femoral head neck junction seen in CAM type FAI. The key distinction here is rheumatoid arthritis is an inflammatory synovial disease, whereas CAM type FAI is a mechanical impingement caused by abnormal bone morphology. Why not septic arthritis? Septic arthritis presents with acute onset of severe joint pain, fever, and joint swelling due to infection, rather than a chronic structural deformity of the hip joint. The key distinction is septic arthritis is acute process. All right. It is an acute thing. It's an infectious thing. It comes with fever. You don't see those things in FAI. Why not gout? Gout is monosodium urate crystal deposition, leading to episodic inflammatory arthritis, most commonly affecting the first metatarsophalangeal joint and is not associated with femoral head neck deformity. The key distinction is gout is a crystal induced inflammatory arthritis, whereas CAM type FAI is due to structural deformity of the femoral head neck junction. So, super formula like looking at keywords and going to your answer in a few seconds. If you see an young active patient, there is deep creep, groin pain, there is decreased internal rotation at the hip, positive aphasia test, there is a pistol grip deformity, and there is a prior history of adolescent hip disorder. It's scam type FEI. So either they can give you that FEI is the problem and identify which is the risk factor, like we saw in this question, or sometimes they may give a CFE in the question stem as the prior history and ask you to identify what disease this patient has in the options. Okay, it can go both ways. So the super point, cam type femoroacetabular impingement commonly develops from residual deformity after slipped capital femoral epiphysis, leading to a femoral head neck bump that causes impingement and early osteoarthritis. All right, folks, let us go to the next question. This is very long, but long questions are coming very frequently. So be comfortable with these long questions also. You need to um, learn the time management, especially when these long things to identify. That's why I'm giving you super formulas to identify certain keywords and go to the correct answer. So let us see this one. A 19-year-old male collegiate hockey player presented with a 1 year history of progressive left groin pain. He described a deep aching sensation in the anterior hip that became sharp during cocking phase of his skating stride, hip flexion and external rotation, and when performing off-ice deep squats and lunges. He denied any specific injury but noted that his hip increasingly felt blocked or jammed, limiting his ability to get low in a defensive stance. His past medical history was unremarkable. Physical examination revealed a significant reduction in the left hip internal rotation, 5 degrees compared to 35 on the right, and a positive anterior impingement test, FADIR, flexion, adduction, internal rotation, which precisely reproduced his sharp groin pain. The log rule test was painless and there was no ligamentous laxity. Radiographs, AP pelvis, and cross table lateral and magnetic resonance arthrogram confirmed pincer lesion and revealed a degenerative tear of the anterosuperior labrum with associated chondral thinning. The patient underwent an initial 12-week trial of conservative management, including activity modification, cessation of deep hip flexion loading, switching from squats to glute bridges. Physical therapy focused on posterior capsular stretching and core stabilization to reduce anterior pelvic tilt, and a brief course of oral NSAIDs. Which of the following is characteristic of this condition? So this is a beautiful question again, and you need to identify the correct answer here. All right. So look at this question step. What is he saying? So we are looking at a 19-year-old male. He has a history of progressive left groin pain and anterior hip aching sensation. And with all this story, you go to this one. There is positive FADIR test, and radiographs are showing pincer lesion. All right, that's a big clue that this is pincer type FAI. All right. Now, once you found out the diagnosis, this is a two-step question. First, you need to figure out what is the diagnosis, and then you should figure out what is the pathology. So first you go through that question stem, you see that it is a pincer lesion, and then you need to think about what is the pathology of the pincer lesion. So the pathology is this one, B, acetabular retroversion. So I already told you earlier, and if you remember that, and then this question is an easy question, okay? I showed you. All right, this is the pincer lesion. So in normal, if you see this normal acetabular coverage, but here you are seeing a over coverage. All right, look at this MRI here. The anterior lip and the posterior lip, they are going too far. All right, so let us say this is femoral head, then this is a stabulum. All right, this should be the normal. Okay, that is the normal, but this is the femoral head and the stabulum is covering so much, almost like that. Then we say that is acetabular retroversion. Why? The anterior lip is too big, and the posterior lip, even though it is big, it is not as big as the anterior lip. So you are creating that backwardness. That's why it's called retroversion, acetabular retroversion. So you see these x-rays. I'm not sure whether you can see it. The normal one is just attaching. Like for example, this is the stabulum, and this is femoral head. This is normal. Okay, this is normal. But when acetabular is covering too much, and when the anterior surface is going too much, what is happening? The femur is going back like that. So Acetabular retroversion is happening. And this is characteristic of pincer type FAI. All right, folks, and you will see that very nicely on MRIs. When you take MRI, like for example, here you see the cross section. You see the femoral head here, and you see the anterior acetabular surface and the posterior acetabular surface. They are almost going too far. All right, we say this crossover sign and the figure of eight sign and acetabular retroversion or acetabular over coverage. So the key radiographic feature of pincer type FAI is acetabular retroversion, in which the acetabular opening is oriented more posteriorly rather than anteriorly. This abnormal orientation can be identified on imaging by crossover sign, where the anterior acetabular wall projects more laterally than the posterior wall. In some cases, pincer deformity produces a characteristic figure of eight appearance on anteroposterior AP radiographs of the hip, although this finding can be subtle and requires precise patient positioning. For this reason, CT imaging is often more reliable for detecting acetabular retroversion and confirming the diagnosis. Clinically, patients often young, active individuals who present with insidious onset deep groin pain, decreased hip range of motion, and positive FADIR test. Recognition of pincer type FAI is important because it represents mechanical cause of hip pain and early osteoarthritis. And early diagnosis allows for appropriate management aimed at reducing impingement and preserving joint function. So the supermnemonic, how do you remember? Pincer 8 car. That is the mnemonic I use. Pincer 8 car. It almost sounds like a race car. Pincer 8 car. So in pincer type FAI, you see 8, figure of 8 appearance on radiographs. C for crossover sign. AR for acetabular retroversion. So 8 for figure of 8 appearance. So that can come as a question by itself. Then there is crossover sign that can come as a question. Then there is acetabular retroversion that can come as a question. So this mnemonic encompasses so many things. So it's better worth remembering that. Then we will go to incorrect answers. Femoral head overgrowth. All right, when you see, why not femoral head overgrowth? Well, femoral head overgrowth, we see a bony prominence at the femoral head neck junction that is characteristic of CAM type FEI. All right, we already talked about that. So the key distinction is CAM type FEI is caused by a femoral head neck deformity, whereas pincer type FEI is caused by acetabular or coverage and retroversion. Why not labral calcification? Labral calcification may occur as a secondary finding due to chronic impingement, but it is not the primary defining feature of pincer type FAI. So, for example, if they give you labral injury, that is the very first thing that can happen in these patients, labral injury. But that is non-specific. Okay, we are talking here about what is specific to pincer type FAI, retro version. So, labral calcification is a secondary consequence of impingement, whereas acetabular retroversion is a primary structural abnormality causing pincer FAI. Then, femoral neck fracture. Femoral neck fractures typically present with acute onset of severe hip pain following trauma and inability to bear weight, unlike the chronic activity related pain seen in FAI. Key distinction: femoral neck fracture is an acute traumatic condition, whereas pincer type FAI is a chronic mechanical impingement disorder. Next, synovial cyst formation. Synovial cysts are herniation pits. So these are seen in these patients, but they are not characteristic or diagnostic of pincer type FAI. So key distinction is synovial cysts are secondary or incidental findings, whereas acetabular retroversion is a defining radiographic feature of pincer FAI. So, if you see an young patient, positive FADIR test, crossover sign, acetabular retroversion, figure of eight, that is pincer type. All right. You see how quickly you can find the answer. So, Go through this super formula. If you see these particular keywords, you would know what is the correct answer. The super point here is pincer type femoroacetabular impingement is caused by acetabular over coverage, often due to retroversion, leading to labral compression and progressive joint damage that results in early osteoarthritis. All right, folks. Next question. A 27-year-old female recreational soccer player presents to the sports medicine clinic with a 9-month history of insidious right groin pain. The pain is sharp and deep seated, rated 6 by 10 at rest and 9 by 10 with activity. It is exacerbated by kicking the ball, pivoting, prolonged sitting, especially in low seats, squatting and getting in and out of a car. She notes occasional mechanical catching and stiffness in the hip after activity, but denies locking, giving way, or instability. There is no history of trauma, prior hip problems, or systemic symptoms such as fever, weight loss, or night pain. She has tried ibuprofen and physical therapy focused on hip strengthening without significant relief. Past medical history is unremarkable. She takes oral contraceptives and has no allergies. She is otherwise healthy and denies smoking or recreational drug use. On physical examination, she walks with a slight antalgic gait favoring the right side. Right hip range of motion shows flexion to 110 degrees, internal rotation to 10 degrees compared with 30 degrees on the left, and external rotation symmetric at 45 degrees, flexion, adduction, internal rotation, FADI test reproduces or exact groin pain, the flexion, abduction, external rotation, FABER test causes mild discomfort but no posterior pain. There is no tenderness over the greater trochanter, sacroiliac joint, or pubic symphysis. Neurovascular examination is normal. Strength is 5 by 5 throughout, including hip flexors and abductors. Plain radiographs of the right hip, AP pelvis, and done lateral views demonstrate a mild cam deformity at the femoral head neck junction, alpha angle 62 degrees with a normal lateral center edge angle and no acetabular retroversion or crossover sign. If left untreated, this condition most commonly leads to. So they told you a long story. Basically, they're telling you it is a camp type, and now, if left untreated, what is going to happen? All right, folks. Let us see. I will give you a few moments. Please get the right answer. So here the right answer. This commonly leads to early osteoarthritis. So I told you earlier, if you have listened carefully, that if you see these hip joints, okay, what is happening? There is so much friction here. All right, this friction is damaging the labrum and cartilage, and that ultimately leads to early osteoarthritis. So the correct answer here is C. This is the natural history of cam type femoroacetabular impingement. All right. So, femoroacetabular impingement, particularly the cam type, is a structural abnormality of the hip in which a bony prominence at the femoral head neck junction disrupts the normal smooth articulation of the joint during hip flexion and rotation. This abnormal contour leads to repetitive mechanical impingement against the acetabular rim, resulting in progressive damage to acetabular labrum and articular cartilage. All right. So clinically, patients are typically active young adults. I told you, increased alpha angle. So if you left untreated, early onset osteoarthritis happens. How do you remember? FAI, OA eventually. Remember, FAI, OA eventually. FAI is equals to OA. Remember that one mnemonic. So if you do not treat FAI, you are going to see osteoarthritis. So, septic arthritis, no. Why? Because septic arthritis is joint pain, fever, inability to bear weight, elevated inflammatory markers. But there is no relationship between the two. All right. Femoroacetabular impingement is a chronic mechanical condition. So septic arthritis is an acute infectious process, okay? Whereas FAI is a chronic mechanical impingement disorder leading to degeneration over time. Why not osteosarcoma? Osteosarcoma is a primary malignant bone tumor seen in adolescents, presenting with localized bone pain and characteristic radiographic findings such as a sunburst pattern, unlike FAI, which is a benign structural abnormality of the hip joint. So, osteosarcoma is a malignant tumor, but that's not going to happen in these patients. Why not avascular necrosis? Avascular necrosis is due to loss of blood supply to the femoral head. All right, so it's a vascular compromise leading to bone death, whereas FAI results in repetitive mechanical impingement. Ankylosing spondylitis, it's a chronic inflammatory disease affecting axial skeleton, characterized by bone, back pain, sacroiliitis, HLA-B27 association. So, ankylosing spondylitis is a systemic inflammatory condition affecting spine and sacroiliac joints, whereas FAI is a localized mechanical hip disorder. So, the correct answer is cartilage damage, early osteoarthritis. That is the correct answer. So, if you see those things like patient coming with FAI, what can happen? Choose that answer. Early osteoarthritis. So, femoroacetabular impingement is a mechanical hip disorder in young active patients that causes repetitive labral cartilage damage, ultimately leading to early osteoarthritis. All right, folks. So, we have been looking at so many things, and finally, let me close this very, very interesting question. And again, they will give you this big story, all right, and read through this big story. But at the end of the day, what they are asking as you prepare treatment plans for this patient, he asks about expected outcomes of treatment. Which of the following is the most accurate statement? So the treatment is the focus here. Which is most accurate? A. Only surgical treatment provides symptom improvement. B. Non surgical management is ineffective. C. Open surgery has better outcomes than arthroscopy. D. Surgery completely prevents osteoarthritis. E. Both surgical and non surgical treatments show short term improvement. So, this question also is going in two parts. Like, for example, first you need to go through this question stem. So the patient has progressive hip pain, groin pain, and the pain is when he squats it is becoming back. There is a stiffness in the morning. That is all non-specific. But when you come to the examination, like for example, the range of motion is limited, FADAR test is character. So FADAR test is specific to FAI, right? So FADAR test that gives you a strong clue where this is going. And then more things are happening here. A bony prominence at the femoral head neck junction, at the anterolateral femoral head neck junction with an alpha angle 68. So, alpha angle is more than 55. You are looking at cam type FAI, and there is mild acetabular bower coverage. So, when you say mild acetabular bower coverage, don't think it is pincer type. You see, most commonly we see mixed types. All right, there will be a little bit of acetabular bower coverage. There is a more alpha angle, that kind of stuff. So when they will tell you what is the predominant type. All right. So here you see a mild acetabular bower coverage and a positive crossover sign. So be that as it may, I mean the question is not about which type. It's more about how you are going to treat it, right? So the treatment here, uh, they gave you five things. Only surgical treatment provides symptom improvement. That is not correct because you start with conservative treatment like physical therapy, NSAIDs, and all those things. And then non surgical management is ineffective. That is not true because, as I said, conservative treatment, that is non surgical treatment, is effective. Then, open surgery has better outcomes than arthroscopy. That is also not right, because arthroscopy has better results, all right, than open surgery. So that's why almost every place they are doing arthroscopy these days, because it is more effective. And then surgery completely prevents osteoarthritis. That is also incorrect, because whether you do conservative treatment or surgical treatment, you cannot completely prevent osteoarthritis. You may reduce the risk of osteoarthritis, but completely you're not getting rid of that risk. So the only thing left is E. All right. Both surgical and non-surgical treatments show short-term improvements. All right. For that's how you remove answers and go to the correct answer. So femoroacetabular impingement is a structural hip disorder, and we already discussed about those things. And the management goes in a stepwise approach. There is non-surgical therapy, activity modification, NSAIDs, physical therapy. Most commonly, there is arthroscopic correction of the underlying deformity, and it has been shown to have better outcomes than open procedures. Both conservative and surgical treatments can provide short term symptom relief, but neither approach fully eliminates the risk of progression to early osteoarthritis, making FAI a clinically significant cause of long term hip morbidity. So, when you are giving treatment, always tell patients that, well, osteoarthritis can still happen, whether you go through non surgical or surgical treatment. But the good news is the risk is reduced. So, how do you remember? The super mnemonic is here is FAI care, both care and repair help. All right. So, FAI care, both care and repair. That means like non-surgical care, conservative treatments will help, repair, surgical repairs, both will help you. So I already discussed incorrect answers. The key distinction: both conservative and surgical treatments can improve symptoms, making it incorrect to say that only surgery is effective. B. Non-surgical management is ineffective. That is also incorrect. Non-surgical management is not ineffective. It is the initial recommended treatment, especially in early and moderate disease. Then open surgery has better outcomes than arthroscopy. Current evidence shows that arthroscopic surgery has better short term and long term outcomes compared to open procedures, with less morbidity and faster recovery. Arthroscopy is preferred over open surgery, making this statement incorrect. Surgery completely prevents osteoarthritis. That is wrong. Although surgery can improve symptoms and function, FAI often progresses to osteoarthritis even after surgical correction, as joint damage may already be present. Surgery does not eliminate the risk of osteoarthritis, only improves symptoms and may slow progression. So the key concept is that both conservative and surgical treatments improve symptoms of FAI, but arthroscopy is preferred over open surgery, and neither approach completely prevents progression to osteoarthritis. So both conservative and surgical treatments improve short-term management. All right. So when you are, that is the FEI management. So super point here, femoroacetabular impingement is managed stepwise with initial conservative therapy followed by arthroscopic surgery if symptoms persist. And both approaches provide short-term symptom relief but do not eliminate the risk of osteoarthritis. All right, folks. So I've seen so many dimensions of FAI today, okay? Like starting from how many types of FAI, cam type, pincer type, what is the pathology in both types. We have seen the epidemiology, like who is the typical patient. We have seen etiology, what types of conditions can lead to FAI. We have seen the long term, the natural history of this disorder, what things might happen to these patients, whether you treat them or not treat them. And we have seen what kind of treatments help these patients. Okay, so folks, you have covered. Definitely you will get some questions from this topic, whether it's USMLE step 1, step 2, step 3, or board exams, and even NEET PG. So I hope this lecture helped you. Please visit us at www.superpoints.ai. Superpoints is all about learning the high yield, the top high yield super points, so that you will achieve super score in your exam and go to that dream spot in that dream hospital. All right, folks, visit us regularly, and these lectures, as we give every week, uh, will be very helpful for your examination. Please subscribe to our channel, get notifications, like and share these videos to your friends, because all these courses are free of cost to you. Thank you so much. God bless you.